we will reconvene, and we're going to talk about high-sensitive troponins. They start in your book on page 87. Got a dozen or so articles to look at this issue. And I don't know how many of you were as uninformed as I was. I remember I was working and I got a lab test back on a patient. I was like, what'd they do with the decimal point? I was like, you mean 0.1? No, 0.01. I was like, wait a minute, what, you know? And so I was totally unaware that we had changed platform from a traditional troponin testing to an ultrasensitive troponin. And then I started educating myself about it. We did a full chapter in this course 2 years ago with 34 papers on it, and prepared that as well as this talk. And so we're going to sort of look at where the literature has moved on this topic and what you need to know about the highly sensitive or ultrasensitive troponins, and talk a little bit about their pluses and minuses. They have both. That pertain to them, and look at specifically at some of the papers that deal with the issue. The first thing is we talk all the time up here about sensitivity and specificity in terms of the scientific meaning of them, right? That's different from saying the test is ultra-sensitive. We're not talking about scientific sensitivity. We're talking about how sensitive the test is for the molecules of troponin, right? Remember, troponin comes in a bunch of flavors. Troponin C is cardiac and skeletal, troponin I is cardiac only, and troponin T is cardiac only. And so we're hoping to identify cardiac injury by looking for the troponin I or troponin T molecule in your serum. These new tests are anywhere from 1,000 to 10,000 times more sensitive at finding those molecules in your serum. So if there's any of those molecules out there, these tests will find them, and they'll find them with fairly high accuracy, meaning that if you were to do a bunch of samples at the same time, they would give you the same results. So the confidence intervals around them are pretty tight. So that's good. Their accuracy, that's what we're talking about, is high, and they'll find troponin if it's out there. Now, one of the things that we've learned over the years is that, so troponin, and we're talking about troponin T and troponin I, are found only in cardiac muscle tissue. The problem is that cardiac muscle tissue isn't only found in the heart. So for those of you who have this concept that your heart is like a pump and then a plumber came in and attached a pipe to it here and attached a pipe to it there, that's actually not how it works. There's sleeves of myocardial tissue that run up into the base of your aorta. It's not like it's screwed together. It's not like it's spot welded. The tissue sort of meld in a braided blend up into your aorta, and they meld into a braided blend out into your pulmonary arteries. And we learned a lot about this, for example, when cardiothoracic surgeons started doing these maze procedures where they ablate everything in your atrium from talking to your ventricle to prevent you from having AFib. And they went, there, we've ablated the atrium. Let's see how the patient does. Shit, they're in AFib. And they'd be like, how the hell could that happen? We just basically severed the conducting tissue of the atrium from the ventricle. How could they be in AFib? Well, it turns out that a quarter of AFib should be called pulmonary artery fib. It's coming from pulmonary arterial sources where there's cardiac tissue in the pulmonary artery. So then they had to change the maze procedure to isolate out the pulmonary arteries as well. And then they went, there you go, it worked. And the same is true with this. So that's one thing you got to know, that if there was stress on the tissues in your pulmonary artery or stress on the tissues in your aorta, and you had a test that's looking for any little tiny bit of troponin, you're going to find it. And so this test is so sensitive that even if you torture your heart a little bit and make it really work hard in the setting of an SVT, let's see how you do going at 220, or I'm getting tired, and maybe you'll release a little troponin. And maybe if you're in bad CHF and you're working hard, you'll release a little troponin. And if you're in renal failure and you can't clear the stuff, the levels might back up a little bit because this test is so sensitive. So what we gained in specificity, now we're talking about the scientific terms specificity and sensitivity. Sorry, what we gained in sensitivity, not specificity, what we gained in sensitivity, we have possibly lost in specificity. And so if you're going to use this test, you got to be clear about what the diagnoses you're entertaining is. So if it's chest pain and it's a positive troponin, that doesn't necessarily mean it's ACS. It could be their aorta, could be dissection. If it's chest pain and it's shortness of breath and you got a troponin on them and it's positive, it might be a pulmonary embolus. If it's chest pain and it's a positive troponin, it might be pericarditis or myocarditis. If it's chest pain and it's a positive troponin, there are a variety of other entities. It's not just looking for ischemic acute coronary syndrome, because the ability of this to pick up some troponin molecules in your serum is so great that it's going to find them even if there's a few of them out there. Whether they're released from some cardiac tissue in your pulmonary sleeves or in your aortic sleeve, and even if you just push too hard on the heart and get to a point where it's in an oxygen debt situation, you might get some, even though you haven't infarcted or it's not angina. So that's the first thing to know. Now, we define the normal as going backwards. We draw troponin levels on a bunch of people, and then we find all the people who didn't have a cardiac problem, and we set the 99th percentile there, and that's normal. So your labs have to do that, and then that becomes the normal reference value for your lab. Okay? The other thing about troponin you need to know is that unlike myoglobin, which goes up sharply and comes down sharply, and I remember the old days LDH came up, some of you probably remember when we did LDHs, it came up and stayed up for a long time. Troponins stay up for 5 to 7 days. So it comes out very early. We're looking for really low amounts of it in these tests, and it stays up for 5 to 7 days regardless of where it was released from. So we've got a bunch of other stuff. Now, there was one other problem that happened in a lot of these papers, and many of you know. How many of you are doing just troponins alone in your hospital? You're not doing myoglobins or any of these other things. We're doing troponins alone. And how many of you are using an ultrasensitive or a highly sensitive troponin? So most people have swapped their platform out now. That's where we're at. And one of the things that happened was we started defining a whole new group of people who were NSTEMIs, who would have been old troponin negative, but are now new troponin positive. So we've expanded the NSTEMI group. That's kind of helpful because it helps you have a reason to admit those when you've got these positives with a non-diagnostic EKG. So that's one thing that's happened. But we've also sort of had increased the chances of us mislabeling something as an acute coronary syndrome that isn't. So I think one of the enhanced burdens of a highly sensitive troponin is you've got to be thinking actively when you're seeing your chest pain patients, and you have to entertain a variety of other diagnoses. In the last course 2 years ago, we looked at a whole bunch of papers that looked at all the disease entities that have been documented highly sensitive troponin positive. And I just want to read the list because it's important. PE, aortic dissection, sepsis, cor pulmonale, pericarditis, myocarditis, renal failure. One study even found it in DKA patients who were sick and being pushed. Tachydysrhythmies, PSVT and AFib, aortic stenosis, hypertensive emergencies, and taser shock, for those of you who have close encounters with the police, have all been documented to have troponin release. So you got to keep your thinking cap on if you've changed over to the highly sensitive troponin test. Now, on the flip side, the real plus of the troponin is, if you got 2 negative troponins on someone in a relatively short time period, we're going to talk about the delta, in a relatively short time period, who the only diagnosis that you were particularly worried about was, is this ACS, and they're both negative, you could probably pretty much say they don't have it. And then you could move to an outpatient setting for further workup and testing. So that's what we want, right? We want that, and we want it to be fast. Now, the accuracy, this chapter doesn't talk about the accuracy, but the accuracy of the test, the fact that you get the same number and the confidence intervals are tight, is actually really important, because the confidence intervals and the accuracy of the test determines when it makes sense to resample again. And so, with the old CPK-MB, the standard resampling time was 8 hours because the confidence intervals are wide. And you could be positive and rising and still be within normal. There were a bunch of papers that showed us that. You had a normal first CPK-MB, you had a normal second CPK-MB, but it doubled. That's acute coronary syndrome, even though both tests were normal. So in this test, the sampling intervals that have been looked at, there are a bunch of papers that say you can drop your sampling intervals to Q2 or Q3 hours. That's pretty useful for us because Q8 hours sucks. Now I'm condemned to go to an OBS unit or a chest pain unit or something. But if you can get me to Q2 or Q3, I can see them at time 0, get one, and in 3 hours when I've got a bunch of data back and maybe a second EKG and some other stuff, and things are negative, I can actually use this to get to a more rapid rule out and outpatient management strategy in a time frame that is tolerable for an emergency physician on a shift without creating dozens and dozens of pass-ons or dozens of admissions to a chest pain unit. And so the accuracy of the test, which is good, is pretty important because the confidence intervals are tight, which means that the delta between sampling can shorten up. There's one paper in this series we're going to look at that says you can go to Q1 hour, time 0, time 1 hour, make a decision. So that's at the cutting edge, which, as Greg, who's sitting in the back, would point out to you, which is just ahead of the bleeding edge. That's at the cutting edge of this, and I'm not sure we're ready to go there. Let's look specifically at some of the papers. Baker, number 1, a British author, 2011. This is sort of a general paper, says some of the things I've just been saying. These tests are 1,000 to 10,000 times more sensitive. In fact, they're so sensitive that people ask the question, does it matter whether you draw them from a saline lock or do phlebotomy? Turns out that doing a saline lock versus phlebotomy only causes about a 4 or 5% discordance rate. But that's how sensitive it is. Small amount of dilution in your saline lock might change your results a little bit. They say the cutoff 99% as defined retrospectively looking at your ACS people. Negative predictive value very high, but specificity is lost. As I pointed out, lots of other disease entities. So it's positive in more non-cardiac conditions, including that list I read to you. You can have increases within normal with this that still are important. So some of you have, how many of you have an indeterminate range still listed on your lab? So we don't have the indeterminate anymore, and I would encourage you to think of indeterminate as positive. Because one thing about troponins that all of the literature agrees upon is a positive troponin increases your risk of badness. We don't know which badness you got, but in every study that looks at it, a positive troponin says you have an increased risk of dying down the road. Might not be from ACS, it might be from your aortic dissection. I don't like the indeterminate troponin because you can rise within the indeterminate range. If it's rising and you have indeterminate in your labs, I would tell you consider that to be positive. I think that's a reasonable take from this literature. Our lab has dispensed with the indeterminate. It's either negative or positive. It has an earlier rise. It's positive usually by about 4 hours of symptoms. Now that's important to note, 4 hours of symptoms. Remember, patients are really variable with when they show up. Some show up right as their symptoms start, some show up tomorrow. So you got to pay attention to that. If you're hyperacute, the person got chest pain and came straight into the emergency department, they didn't do what a lot of people did. They sort of mulled around, you know that move. They try some Mylanta. My doctor said Mylanta, and boy was he wrong. You know that's the case when they come in with Mylanta with CPR in progress. You know, that's, my doctor said Mylanta and they were wrong. But a lot of people sort of, molder around with it for a couple of hours before they come in. Some people come straight in. But earlier rise. The optimal interval for testing, this paper touches on it, says it's not answer, and this paper says you could consider going down to delta 2 hours. Certainly delta 3 has been looked at in a bunch of papers. It notes the tight confidence intervals, and I will point out, not noted in this paper, that the Laboratory Society of the United States, and I disagree with this conclusion, and I suspect Greg, who does a lot of medical legal review more than I do, would join me on this. The Laboratory Society says that if you have 12 hours of symptoms, and there's another paper that says 6 hours of symptoms, and you have a single negative troponin, you're done. I'm like, you're going to get 2 EKGs. If they give me a short delta, I'm doing 2. I'm doing 2. But anyway, it's there. Let's jump to abstract 2. This is a New Zealand paper. And a lot of these papers do the kinds of things that you would like to know. This is a good one, I think. It's 939, so basically 1,000 low-risk chest pain patients, normal EKGs. Whenever you hear the papers that included the STEMIs, I don't care about the STEMIs. I don't need the lab tests on the STEMIs. Take them out. I don't want them polluting this idea. I want to know low-risk chest pain with a normal or quasi-normal EKG, what does the test do for me? That's what I want to know, and this paper does that. And they did 0, 2, 6, and 12-hour sampling. I love this paper because the Kiwis did 2. I love 2 hours. Sensitivity, specificity, and accuracy at time 0, 88, 82, and 83, pretty darn good. And by 2 hours, the sensitivity was up to 92%. That's pretty darn good for a serum marker. It's better than any serum marker in history has ever performed. It still doesn't mean, if we accept the miss rate for ACS across emergency medicine is 2%, that means we're already at 98% sensitivity. So maybe you would look at this, another way to look at this is we're already doing better than the test right now. How much does the test add independent discrimination to this? But I think it does add some. But the point here that I take home from the Kiwi paper is the second trope adds diagnostic yield when you're talking about these highly sensitive tropes. The second troponin, because it's rising early and rising fast, the second troponin, 2 hours, even at 2 hours, it adds independent increase in sensitivity. By the way, what was the hazard ratio in this paper for a positive troponin? Hazard ratio for death, if you have a positive troponin, you're 5 times more likely to die. We don't know what you're dying of, necessarily, as I pointed out. Hazard ratio for CHF, by the way, hazard ratios of sort of 5, you get, 2 to 3 times sounds really good, but actually clinically that's sort of average, kind of, it doesn't really help you that much. Once you get to double digits of hazard ratios, you're really talking it's important. Hazard ratio for CHF, 28. And hazard ratio for a non-fatal MI, 4. So the test is, you may have, how many of you have heard Amal Mattu saying, throw this thing out? Too sensitive. You may have heard that. I disagree. I would agree with Amal that you've got to keep thinking if you're going to use this, because it's going to be positive in a much wider array of conditions. But I'm interested in the negatives and reaching the negatives quickly. And if this test is accurate enough to allow me to do delta 2-hour sampling, I don't want to throw that baby out with the bathwater. And its test performance is pretty good. The author of this chapter, by the way, is Dave Newman. He also wrote that PEDS paper about the UTIs. He's one of our faculty here. Maybe we should have given you that disclaimer. And he's a very smart guy. He's a little less enthusiastic about this than I am. I acknowledge the problems. The lack of specificity is a huge problem, but the sensitivity and the shorter sampling time is a big plus. And I think that it's most everyone with common sense has acknowledged that as well, which is part of the reason we moved so quickly to this platform when it came out. Abstract 3, a Swiss paper, points out this, and I already kind of alluded to it, that a positive troponin increases your chance of death in the short term, the medium term, and the long term. So the idea that there's some intermediate positive troponin that you need to not worry about, if you've got the intermediate result on your test panel, be very careful with that. A positive troponin is not good. You always hear the cardiologists come down and they'll love to tell you that these papers, oh, you're crying wolf, you're the emergency physician. And they come down and they talk like your heart is plumbing. Oh, it's just a troponin leak. Like if you got in there with a little plumber's tape, you can fix that. Oh, it's just a little plumber's tape, you'll be fine, it's a leak. I don't think the leak concept is a game you want to play often. You need to entertain that there are other conditions that can cause small amounts of troponin to come out, but the idea, oh, it's just a troponin leak, there's nothing to worry about, the literature to me doesn't support that idea. However, Abstract 3 also points out that 1/3 of ACS patients had a negative troponin at time 0. That's time 0 being not onset of symptoms, but presentation in the emergency room. It's another piece of data that says to me that, yes, it's a really sensitive test, but if you're getting 1, you're getting 2. 1/3 were negative on the initial. So if you want to get up to these numbers on the Kiwi paper with a sensitivity 92%, you're doing 2, at least. Abstract 4, boy, is this a weird study. I love this. I kind of love it, though, and it shows that people are kind of looking things. What did they do in this paper? What they did was they said, we have this blood that we saved from the Gusto 4 trial that was done back in 1999. Remember that trial? It was abciximab. It was looking at a glycoprotein 2B3A inhibitor. And when we were trying to, back in that day, wrap our head around these glycoprotein inhibitors, all the trials had spectrum bias in that they really wanted a sick group of people in there so that it could show this drug might save a few lives, right? If you want to show your drug can save people, then you need a bunch of people dying in the group. So you could say, hey, see, 1 or 2 less people died. So this was a very sick group, and they had this blood. And so they took 1,400 of these old samples, which they knew their outcomes on, they knew what they had, from the abciximab trial, and they said, yeah, what do you say we just run them for Trop? They've been on ice. They're still good. Run them for troponins. So that's what they did. It's a freaky idea. And they found, and by the way, in that trial, at the time this trial was done, Gusto 4, they were using the old troponin tests, not the regular troponin T. And when they ran it for the ultra-sensitive, the highly sensitive troponin T, they found that 16% of those that were negative in that old trial were positive on this. Again, pointing out that these add discriminatory and power and the ability to pick up one of the diseases we're very interested, which is ACS. And so that I find interesting, even though it's kind of a weird thing. Why would we be looking back at this old blood? Because we knew a lot about the patients with that old blood, and we still had it available. And they showed that it was better than the older test. 5 is a UK study of 703 patients where they were hoping to get to a 4 to 6 hour rule-out strategy that doesn't catch too much of this other garbage I'm talking about due to its non-specificity. I'd actually like something faster than 4 to 6. I'd love to be done with this in 3 or 4 hours if I could. And I think we can get there with these, which is why there's still a lot of interest. And they compared the old troponin with the new one. And this paper says that when they compared it to the old route, using the older testing, AMI, acute myocardial was excluded 10 hours earlier because the old troponin T, they couldn't sample at less than 6 hours because it had wider confidence intervals. So the results took another hour or 2 to get, and then discharge was 9 hours. So AMI excluded 10 hours earlier. It would have eliminated workup. Now here's the one we want, right? Where there are 2 negative ones. It would have eliminated workup in 27% of patients and decreased admissions to a chest pain unit. I like that. And because this was in a study setting where they really had a group of patients where ACS was the only concern in them, right? That's what happens in study settings. They're very careful about who gets entered into the study. There wasn't much garbage. There wasn't many other diagnoses. That's not necessarily true for the way you might be using it. I think the way we use it in our department, you need to expect that if you were fishing for tuna, you need to expect that net to be coming up with some dolphins, some rock cod, a bunch of other shit's going to be in the net. And you're going to have to keep thinking about it. 6 is an Aussie paper with 1,000 patients. One of the things about when you look at these papers is you want to know how many of the patients ultimately turned out to have an acute myocardial infarction, because that tells you what kind of fishing they were doing. So if you see a paper where 30% of the people ultimately have AMI, ask yourself, is that the kind of people you're troponin testing on? I don't think so. In our hospital, we're talking maybe 5 to 10% of them. So a lot of these papers are higher than that. So for example, in the last paper we looked at, in this paper that we're talking about, 14%. The Aussies don't work everyone up. They're a little more selective. That's a higher rate than I would find in my hospital. T equals 0 times 0, arrival to the emergency room. Sensitivity 77%, negative predictive value, again the thing we kind of want in terms of stopping with what we're doing, 96%, pretty darn good. I'm going to skip 7 because it's got low power. We're going to go to 8 and 9. 2 New England Journal papers published the same week. One is the Apache, it's got no H in it, but it's the advantageous prediction of acute coronary evaluation. In that study, 17% ultimately had MI, and in the next one, 22%. So again, these are pretty sick groups they're looking at, a little sicker than what we would like. That's going to make the test look better. And what they did was they compared a bunch of, because there's multiple platforms for these highly sensitive. There's Abbott, there's Roche, there's Siemens, and they compared them. And in Abstract 8, basically they said all of the highly sensitive troponins did better than the old ones, and that the new tests had better area under the curve for the disease we were looking for, and none of them was a clear-cut winner head-to-head. So it didn't seem to matter. You know how we talked a lot about the old days about D-dimer platforms? What platform do you have? What generation? One of the questions that we had and that this paper talks to is, does it matter a lot which highly sensitive troponin platform you got? And in this paper, at least, the platforms all performed very, very similarly. So it didn't matter. You didn't have to go shopping specifically for the Roche, the Siemens, the Abbott, whichever one. They all did pretty well. Abstract 9, Kellers Paper, which is the other New England Journal one, 2,000 patients, 22% with MI. This paper, my problem with it is they mixed in the STEMIs. Don't do that. I don't want the STEMIs in there. So 7% of those patients were STEMI. So that takes us down from 22 minus 7. So the rule-in rate of the non-STEMI group with these tests was 15%. I can live with that. And time zero sensitivities, and if you read this paper and the abstract, in the abstract, because Jerry critiqued the abstract, the sensitivity and specificity numbers don't work out. Because they said that the overall sensitivity was 91% and specificity was 90%, and then they tried to break it down in groups based on how long their pain were, and all the numbers were lower. So you can't have all the lower numbers adding up to a higher sensitivity and specificity, so there's some question about that. Abstract 10 says, all right, so we know how sensitive it is. We're looking for just a few molecules of troponin floating around in your bloodstream. What if the person's got known coronary artery disease? Are they constantly leaking troponin? Can we use the test in people who've been stented, bypassed, things like that? Are they kind of chronically troponin positive with the highly sensitive test? I think it's a totally reasonable question. A lot of you probably haven't thought about it because this paper 10 says, nope, it's not true. Once they've had their procedure and they're over that and they're healed, their troponins go back down, and this traditional normals. They say there might be a little higher cutoff, but basically the concept that you need to think of your troponin normals as different in people with established coronary artery disease is not true. So that's, because if that was true, that would complicate things a lot. So fortunately, that wasn't the case. And that takes us to 11. And 11 is a paper I love, except I don't think we're there yet. This is the cutting edge one right by the bleeding edge. A 1-hour rule out, 2012 paper, multi-center, 900 patients. They had 30-day follow-up. AMI rate overall was 17%. Patients were negative EKG when they started. And 17%, as I said, ruled in. In other words, they had abnormal troponins that were rising, called non-STEMI, put them in the house. 60% were negative, ruled out. Nothing happened to them. They were true negatives. And then there were these intermediate people, for those of you who have that, or they were rising within normal. And by the way, what did this paper say about those? It said they're not negative. They're not intermediate, that you should think of the intermediates as positive. Why so? Because 8% of them ultimately turned out to have ACS. So again, another paper saying that if your lab reports intermediate, be careful thinking intermediate is, it's nothing. A positive troponin is a positive troponin. And finally, 12 says, yep, if you fish widely with it, you're going to catch stuff. 15% of the positives were non-ACS, although all-cause mortality, again, was higher. And an obvious explanation for a positive troponin, and this is problematic, was found in only about half of them up front. So you were thinking, oh, I got a positive troponin. I was thinking ACS, but oh, maybe I ought to consider PE. And then you find the PE, oh, their positive troponin is due to their PE. They only found the reason in about half. So presumably in the other half, it's some sort of demand ischemia or something that didn't cause anything that they could objectify later on with a complete workup. So there is definitely a loss of specificity if in about half of them you can't figure it out what it was. So I'm going to wrap up, but I just want to say I'm not ready to throw out the highly sensitive, ultra-sensitive troponins. For those of you who kind of heard that side of the debate, I agree with the people who say that you've lost a lot of specificity. You gotta, if you're testing with troponins and chest pain, you still gotta think about the other things that can cause troponins. Notoriously aortic dissection, myocarditis, pericarditis, all that list that I read. And even in some non-specific things like sepsis and DKA, there are documented positive troponins. So you got to keep thinking if you're going to use them. But the plus side of these tests is I can drop sampling time. I'm not ready to go to Q1 hour. I'm not ready to do time 0 and 1. But I'm pretty comfortable doing time 0 and 2 or 0 and 3. I'm already doing that in my practice at LA County now. Doing 0s and 2s, 0s and 3s, that kind of range, and making decisions at that point. It's not perfect, but remember, this is a low-risk group that I'm applying it to. Sure.
Sorry, Billy, the problem I had when I tried to do this in my emergency department was that the cardiologist wouldn't support it.
Yep.
They said it's not been adopted by our national society yet, so you're out of the limit if you do it.
So it's interesting. I certainly, obviously, we don't work in a vacuum, right? You've got to work with your consultants. You've got to have some agreement across. We're only the beginning of the process, and if your cardiologists aren't buying, you can't get there. But there is if you were to just look up the Delta 2 and Delta 3 papers, there's only one Delta 1 that I know of, and we looked at that was the 11. But there's now a growing number of Delta 2 and Delta 3 papers. So I think there's enough for you to open the conversation based on the scientific data that's out there. Whether they come around to it or not, I can't, I have no purchase on your cardiologist. Our cardiologists seem blissfully unaware of what we're doing in the emergency department, and I'm fine with that. Yes? So it's been looked at a bunch of times, and in the last chapter that we did 2 years ago, we looked about adding troponin, is there a reason for still doing a CK or a myoglobin or the old one? And it basically didn't pan out. So this test is superior to those in terms of sensitivity. In terms of specificity, no. Again, there are other disease entities that can have pretty high troponins. An aortic dissection, certainly one that comes back to your aortic valve. Remember, some of them are having true ischemia too, right? If you get a coronary ostia, you're having both an aortic dissection and an acute ischemic event. Greg is giving me the hook.
No, I'm not giving you the hook. What I'm going to say is, if you want to go to time 0 and then 1 hour, I'll give you my card. We have a new name for you. You call the defendant, and there will be people who show up who say that this is not acceptable yet. It's interesting down the pike. I want people out as fast as anybody. Point 2, just because you have 2 negative synthesize, you sent them home, doesn't mean they don't have heart disease.
Right, doesn't mean they don't have angina.
That's exactly right. And I've heard this, they don't have heart disease. That's not the problem. You can't say that. All you can say is they didn't infarct today. They didn't leak.
But I will say this, Greg, and this would be borne out by the absciximab study where they ran the old serums. So those 16% that were newly found in that trial where they looked at the old frozen blood, those were called angina. So we ruled out, we moved some of the anginas into the NSTEMI group with this highly sensitive test. So there's some protection, but certainly no universal protection there. Some protection. Because some of what we used to call angina is now an NSTEMI because this test is more sensitive.